Okay, sir, we are live. We can begin.
So hello everyone, a very good afternoon to all of you. I'm Dr. Vinay Purohit. I'm a pharmaceutical physician and working as a DGM in Medical Affairs Department of Lupin. It gives me immense pleasure to extend to you a very warm welcome on behalf of our entire Lupin team in this special ECME and panel discussion Circle of Ease. We are really very lucky and privileged to have eminent speakers who have connected to us from across India, from different part of India. So we have Dr. P. Balamba, senior most obs and gynae expert, who is joining us from Hyderabad today. Dr. Maninder Ahuja, who is joining us from Delhi, and Dr. Basab Mukherjee, who has joined us from Kolkata. So would just briefly introduce these speakers, although they don't need any introduction. They are the most eminent experts in their field. But Dr. P. Balamba is a former professor and HOD of Department of Obs and Gynae in Osmania Medical College, Hyderabad. She has been former additional superintendent in the same medical college and additional director of medical education, Andhra Pradesh. She is a professor emeritus in the Obs and Gynae from NTR Health University, former president of FPI Hyderabad chapter, and at present consultant in Shalini Hospital, Barkatpura. She had served as vice chairman in AICOG, in the past chairman of organizing committee of AICOG, and has served as former president and secretary. Dr. Maninder Ahuja, she has more than 40 years of experience in menopause as well as adolescent health, apart from gynae and obs expert. She's an expert in high-risk pregnancy, infertility, and founder and president for the Society of Meaningful Life Management. She's author of research article Age of Menopause and author of a book Step by Step Management of Menopause. President of Indian Menopause Society, she has served in 14 and 15, and VP of SAFOMS, South Asian Federation of Menopause Society. She has been a president of FOCG and vice president of FOXY in year 2013 and 14. Dr. Basab Mukherjee from Kolkata, he has done his medical schooling from CMC Vellore. He is a FIGO coordinator of South Asia in Safe Abortion Committee. He has been clinical examiner for RCOG examinations in India and member of governing council of ICOG. He is honorary secretary of Bengal Obs and Gynae Society and served as the vice president of president-elect of FOXY for upcoming 21-22 session, and he is the past chair of Family Welfare Committee of FOXY in 2013 to 15. So with this, we will start with our scientific agenda. So for today's ECME and panel discussion, the first session would be by Dr. Basab Mukherjee on menopause and hormones. So he will explain on scenario in India as well as all the hormonal changes during, before, and after menopause, and what are their effects on the health of women. So over to you, sir, Dr. Basab Mukherjee.
Yes, thank you, Vinay. A very good afternoon to everybody listening to this webinar. It is on menopause. The next 1 hour, myself, Dr. Balamba, and Dr. Maninder Ahuja will be taking you through some aspects of menopause. I'll be starting the ball rolling with menopause and hormonal changes, something which all of you would be aware of and you know, but just trying to bring some perspectives as we carry on the discussion this hour. So menopause is a natural transition in life. There is 3 stages which are not very clearly always defined, but there's a pre-menopause, perimenopause state, or perimenopause state, period before menopause, when the estrogen and hormonal levels begin to drop. It'll be pre-menopause, sorry. Then there'll be a menopause, where the point where a woman no longer has menstrual periods, which is easily identifiable. At this stage, the ovaries have stopped releasing the eggs and producing most of the estrogen. And then the post-menopause period, the period of the time after a woman has not bled for an entire year. So this entire transition from premenopause to perimenopause to menopause and postmenopause can take anywhere between 8 to 10 years. So when a woman comes with irregular bleeding at 42, 43, and she says that, am I entering into menopause? Then we can tell her that it is a retrospective diagnosis. We are not certain, but the entire process may take some time. So the prevalence of menopause, here we understand that premature menopause is increasing for different reasons, which is beyond the scope of today's discussion. And menopause, generally we see in India, the Indian Menopause Society has written the average of around 48. So here we are, so 20% of women between the age of 37 to 40% suffer from premature menopause. And that is something which is important to our fertility specialists, especially the IVF people. And that's why they do all advise to have the biological clock in Indian women may be ticking faster than in the Western women. 65% of women between the age of 40 to 49 have suffered menopause. So there's a high prevalence of women experiencing menopause below the age of 50 and sometimes below 42. So the four female hormones and their functions is something which all of you are aware of. There's no need to bring it out. So the follicle stimulating hormone, the luteinizing hormone, estrogen and progesterone are something which we have heard about and studied in our medical schooling days. The tissues and the organs affected by the estrogen function, well, this is something which we are aware, but in the males, it has an effect on the testis, and on the female, of course, from brain to hearing to hair, pituitary, heart, and a cardiovascular system, which we know, which was the basis of the HERS trials at one time, the liver, skin, colon, immune system, adipose tissue, where the conversion takes place, bone, skeletal muscle, where the sarcopenia is one of the aspects of menopausal changes, and then the breast, ovary, uterus, and vagina. So we know that estrogen has an effect on all these organs, and a lot of this effect is seen when estrogen is deficient in the later part of life. So the protective role of estrogen, what it does in a woman, it facilitates reproduction, of course, increases the lean body mass, reduces abdominal fat, improves insulin resistance, decreases the LDL to HDL ratio, decreases blood pressure, improves endothelial health, maintains bone density. So all of this is a very positive effects of estrogen on a woman. And that's one of the reasons they used to say once upon a time that below 50, the estrogen protects women from cardiovascular events. And after 50, that protection is generally gone. So improves mood and sleep quality, reduces skin wrinkling or hair loss, maintains cognition, moderates appetite, maintains gut and gut microbiome, which is a very hot topic of discussion nowadays, maintains the immune system and modulates inflammation. So the hormone level and age, estrogen production drops rapidly beginning around the age of 40. And we had shown in a chart before, often it decreases even before that. And what does it do to the female body? How does it impact a woman's overall health is what we may be going through in the next few slides. So the hormonal changes which happen during the transition of menopause is that the estrogen decreases as ovaries run out of eggs. And because of the little estrogen, ovulation does not occur, progesterone is not produced, the uterine lining doesn't thicken, thins out, periods do not occur. This is a very good slide to show to the lay people and the public about what exactly happens and how they can relate ovarian function loss to menopause and not uterine function loss. The hormonal changes during the menopause transition, we see that the estrogen and progesterone all reduce. So that the estrogen, the 35% reduction from the age 35 to 50, and a progesterone, there's a 75% reduction from the age of 35 to 50. And that menopause is a relatively high estrogen compared to progesterone. And some of the features of menopausal symptoms, they say, are due to progesterone deficiency initially, along with the estrogen deficiency later. So increased estrogen to progesterone ratio is a major factor in some of the symptoms experienced by women. So this is the bar diagram on the prevalence of the various symptoms which women do experience. So this is the results of one survey, which was published in 2018. It's on the health-related quality of life among menopausal women. And here you see the frequency of hot flushes around 67% in the population which they had surveyed or studied. Sorry. Night sweats 58%, sweating 56, and then 92% had decrease in physical strength, and drying of skin was also there, and feeling tired, difficulty in sleeping is a very common complaint if you ask for it, among others. So the prevalence of physical symptoms was around 75%, vasomotor 60%, psychological 45%, and sexual domains around 26%. Overall, of course, these all symptoms impacted the woman's life, and we do talk about quality of life, and we talk about giving hormone therapy to symptomatic women who have a definite problem which needs correction. The estrogen effects on the woman's body. So estrogen in the bone helps in the development of the bone. When estrogens are present, osteoclasts undergo apoptosis, shifting the balance to an overall maintenance or building of the bone. So it's estrogen is good for bone, putting it simply. But during menopause, estrogen levels decrease, the bone mineral density also decreases. And we know that the density actually decreases much earlier. So at the age of 30 to 35, we know that we have our maximum bone mass, and then it all gradually decreases. And this decline is more steeper around the time of menopause and soon after. So within the first 5 years after menopause, women lose a large amount of trabecular bone, followed by a slower loss for the remaining years of life in both cortical and trabecular bone. And osteoporosis is another discussion, which is a very important discussion and a public health problem which needs to be addressed. So women are at risk of osteoporosis, which can lead to fractures, severely impacting the quality of life and healthy aging. So the other estrogen effects in the woman's body is on the adipose tissue. Adipose tissue, the knowledge has increased over the last couple of decades, and now we understand that this is an organ with an active endocrine function. The underlying mechanism linking the estrogenic regulation in adipose tissue has not been fully elucidated, but it is thought to include interactions of the estrogen receptor signaling effects involving lipolytic and or lipogenic enzyme activity, free fatty acid metabolism, and adipokine cytokine production. In menopausal women, the loss of estrogen signaling produces a preferential increase in visceral fat, which results from both increased adipocyte size and number. So it can cause weight gain and impaired glucose synthesis. The other estrogen effects on a woman's body, which is biological, which happens is on the skin and the hair follicles. Estrogen inhibits skin aging by preventing skin wrinkling and promoting skin thickness, collagen content, and skin moisture. Estrogens have shown to play a supportive role in skin wound healing. And in humans, estrogen may have a stimulatory effect on hair growth, most probably by shortening the resting phase and prolonging the hair growth phase of the hair cycle. So decreasing levels of estrogen can cause skin thinning, which often is the case in the perimenopause and postmenopausal periods. So women use more moisturizers at that time, and increase in the number and depth of wrinkles, increase in skin dryness, and decreased skin firmness and elasticity. Coming to the estrogen effects on the brain. So the estrogen effects receptors are widely distributed in the brain and having important regulatory function on different processes such as cognition, anxiety, body temperature, feeding, and sexual behavior. They exert neuroprotection actions, and the loss of estrogen during aging and natural or surgical menopause is associated with mitochondrial dysfunction, neuroinflammation, synaptic decline, cognitive impairment, and an increased risk of age-related disorders. Skeletal muscles, estrogen is considered to play a crucial role in skeletal muscle hemostasis and exercise capacity. We do understand of a phenomena called sarcopenia, which is muscle loss after menopause. And one of the reasons why that is because of the effect of estrogen on the muscle. So estrogen improves muscle mass and strength, increases the collagen content of connective tissue. So decrease in estrogen can cause decrease in muscle mass and strength. Coming to the cardiovascular system, estrogen keeps blood vessels healthy and pliant and prevents increased inflammation, a huge threat to heart health. It decreases LDL, increases HDL, which we did mention earlier, and estrogen increases endothelial nitric oxide activity, or cardioprotective action, and a decrease in estrogen can negatively impact the cardiovascular system. Coming to the vaginal health, this is another common reason why a lot of postmenopausal women do come to clinicians with problems of vulvovaginitis. So the vaginal health, as you see in the picture, which is quite clear that the vaginal lining is thick and moist when the woman is protected with estrogen during her reproductive years. But after the menopause, the vaginal lining becomes thin, dry, elasticity decreases, and it is more prone to infection, and the protective environment is lost. So decreased levels of estrogen and progesterone lead to reduced blood in the vaginal walls, resulting in atrophy, loss of lubrication, dyspareunia, and work. So in conclusion, for this part of the discussion in menopause, we do admit over the last 10 minutes, we have been able to impress on you that estrogen is an important sex hormone in the female body that plays a very critical role in maintaining an optimum health. While estrogen and their physiological roles have been well characterized in the breast cancer, and in the female reproductive tract, less is known about the direct targets of the estrogen in other tissues. Decreased level of estrogen impacts a woman's life in many ways, thus reducing the overall quality of life, and that is an important issue. Thank you very much. We'll continue with the other presentations, and then we'll take the question and answers in the end.
So thank you very much, Dr. Basab Mukherjee. So would request our next panelist, Dr. P. Balamba ma'am, to take us through the evolution of menopause management. So how the treatment has evolved over the decades, and what are the current treatments and gaps in the treatment. Over to you, ma'am.
Hello, good evening, everybody. And can I have my slides, Tejas? So let us go through what is the evolution of menopause management. From where do we start? It was Aristotle who first said that the menses stop in a woman around the age of 40 years. And then, the WHO started just now, like Dr. Basu Mukherjee said, they thought estrogen prevents heart disease, and then they wanted to study the Women's Health Initiative, and they started this. That is what they wanted to look at, the secondary prevention of cardiovascular diseases. And then, the recruitment of all these women who were above 65 started, and that is when the problems also started. And when in 2002, when they published the report of WHI, the whole thing, because in the mid 70s, people thought that estrogen is the hormone which is going to keep the women forever young and youthful, and everyone was using this hormone. But then once the WHI report came out in 2002 without proper analysis, everyone thought that it is going to increase the cardiovascular problem, increase the stroke, and they forgot that it decreases the colorectal cancer, decreases the fracture incidence in the hip and the lumbar spine, and the normal, beneficial effects of estrogen, which Basab Mukherjee has already alluded to. But then, people got scared because it increases the breast cancer. What people forgot was it was progesterone and not estrogen, which actually increases the incidence of breast cancer, especially in women who have a tendency for ER/PR positive breast cancer. So there was extensive HRT usage before the Women's Health Initiative started, and it was prescribed almost 25 to 30% of peri and postmenopausal women. We will come to the stages of menopause at a later stage. And in Western countries, many people started using this hormone once they reached menopause. Now, immediately after WHI, once the media broke the story, there was a sudden drop in HRT usage. From 25 to 30%, it dropped to 3 to 4%. And the current scenario is, after the post-WHI fiasco, when proper analysis of the results came out, the current scenario started where there is a slight increase in prescription and there is an increasing evidence of risk-benefit weightage, and especially in the period of window of opportunity. So what is the future? Next slide. Yeah. So what is the timeline of evolution of treatment of menopause? In the 70s, it was described that this menopause is a deficiency of estrogen. That is what the endocrinologists thought, and that is why they medicalized the menopause, and they said we have to replace the estrogen so that these symptoms can disappear. So in 1930s, Emeonin was the first commercial product extracted from urine of pregnant women. Before that, in 1938 also, there was this term of menopause was coined from Greek. Meno means month and pas means stopping. So this started then, and people started using, sheep's testes, sheep's ovaries as a replacement, which they were eating with their sandwiches. Then, the pharmaceuticals came into the picture, and they started producing estrogen first from the women's pregnant women's urine, and then they thought it is better to take it from the pregnant mare's urine, that is a female horse's urine. So the first synthesized source of estrogen was diethynyl estradiol, and this went on, and in 1941, the Food and Drug Administration USA approved DES for the treatment of menopause, because estrogen, they thought, can cure all the symptoms of menopause. And then came the discovery of medroxyprogesterone acetate in 1956, and people thought that menopause causes lots of psychological problems in women, and they started using the antidepressants, tranquilizers, and other psychotropics, also increased for the management of menopausal symptoms. Then came the study in 1971 that DES is associated with vaginal cancers and grape-like cancer in the vagina of the girls born to these mothers who had received this DES during their pregnancy. And then again, the whole thing went into disrepute. Next slide. So 1971 to 75, there were lots of changes, like I said. The first thing, the New England Journal published that use of estrogen in these menopausal women increased the incidence of endometrial cancer in these women 7.5 times. So immediately, people stopped using it. Then in 1970, the Menopause Society started. In 1976, there was an international conference of International Menopause Society in Paris, France, about the menopause and what should be done, and the consensus, everything started then. So then they said in 1988, combining progesterone with estrogen in a woman who has an intact uterus prevents the incidence of endometrial cancer. And in 1988, tibolone was introduced, supposed to be a wonderful hormone because it had the androgenic effect, estrogenic effect, progesteronic effect, with the less of the complications. In 1999, the American Endocrinological Society issued guidelines for clinical practice and management of menopause. It was not gynecologists who started it, but it was the endocrinologists who started the treatment then. Then, of course, 2002, the Women's Health Initiative started. Unfortunately, the women who were recruited in this were all beyond 60s, when the window of opportunity was lost, and naturally there were lots of complications with the use of estrogen. And once the results were published, the entire thing came down with a crash, and there was a halt to the usage of estrogen in women who have even menopausal symptoms. Even if they had severe symptoms, they didn't want to use this. And later on, there was a better analysis of WHI and in findings, and then came lots of studies which said that estrogen alone usage does not increase the incidence of breast cancer, but it has to be used only in women who have no uterus. But if there is a uterus, progesterone has to be added at least for 10 to 12 days in a cycle, in a month. And that is how, the whole thing changed. And the whole concept of managing the menopause where, we said we will prevent the secondary prevention of cardiovascular disease was out. So we knew that the hormone therapy is not going to stop the complications, but it has a role in primary prevention if it is started within the first 10 years of menopause. And we can use it. And prevention is not the reason for which it has to be used, but it has to be used for symptoms, and it has to be used in a small dosage for a short period so that the symptoms of hormone deficiency can be alleviated. Next. What is the current scenario? The current scenario is judicious use of hormones. So we know now we have to use it for the symptomatology, to treat the symptomatology, not for any prevention. And it has to be used, not in all people, but in women who need the therapy, and in women who need this only for the symptomatology. Until the symptomatology is cured, we can use it, and then stop using it. And as a matter of fact, there's absolutely no use using the hormone therapy after 65 years if you start it at that point of time. That means the window of opportunity is lost. From the time of menopause to 10 years is the window of opportunity. Now, actually, Dr. Basav was alluding to the stages of menopause. There are two classifications. One was by Dr. Behram Anklesaria. It was modified by IMS, and in fact, it was presented in the International Menopause Conference at Madrid in 2008. Though he wrote it in 96, he published it in 1996. It was introduced in 2008, and then there was a Indian Menopause Society consensus where they modified it to stage 1, 2, and 3. Stage 1 is the perimenopause, where the woman goes through these changes, where the estrogen is slowly decreasing, the number of eggs are slowly coming down. That then culminates into menopause, which is a retrospective diagnosis, where the woman has to stop the periods at least for 12 months. And this period also is considered as perimenopause. And after that, it is postmenopause. Up to 5 years, it is stage 1. And then after 5 years, it's stage 2. And then, it goes on till the end of life. And there is a straw classification also, that is staging of reproductive aging of women. This also, again, when it was published, there were a number of stages. Then it was modified after 10 years, and we can either use that. But I personally feel Anklesary's classification is much better to use, much simpler to use. Now, estrogen therapy is not recommended. Hormone therapy is not recommended. It is not hormone replacement. In fact, hormone replacement therapy is used in women who reach premature ovarian failure or primary ovarian insufficiency. So that is a replacement because they are in the reproductive age group. Whereas when we are giving it in a menopausal woman, it is hormone therapy for the need for the symptomatology. We are treating the symptoms. And the best part of it is the estrogens will prevent the vasomotor symptom. That is the best drug to be used for vasomotor symptoms and also for osteoporosis, because estrogen receptors are there in the bone matrix. This will improve the osteoporosis, and once you stop the estrogen, naturally the process of loss of bone mass again starts. So women above 65 we are not going to use because it is not the window of opportunity, and the lowest dose has to be used. So you start with a higher dose for vasomotor symptoms, then bring it down so that maintain the therapy for some time without extending it beyond 5 years. So, and every 6 months you have to evaluate these women, and before you start this therapy you have to take a very good history, whether there is any cardiovascular event before, whether she is a hypertensive, whether there is a history of breast malignancy in these women, whether any disease, any hormone imbalance which is shown in abnormal uterine bleeding. So all these things have to be recorded, and then the woman has to be counseled very well, and you individualize the treatment. So you don't prescribe hormone therapy to all women who are menopausal, but only individualize so that you treat women who really have a problem. Now, customization of therapy is also very important because the route of delivery of estrogen is also very important. The first pass effect, that is the one through liver, which causes the problems. So there are other routes of administration of estrogen also, like it can be transdermal, it can be even vaginal, especially in urethral syndrome where they have urethral problems or where they have dyspareunia. You can use local use. Local use of estrogen can be done. So you will have to look at other alternatives also. Suppose the woman is apprehensive of using estrogen because of the side effects. Once you counsel, you have to explore the use of non pharmacological alternatives also. That is not synthetic drugs, but other things also, like the plant-based ones. That is how the isoflavones came into picture. And now we have better plant-based drugs also coming into picture. Next. Next. So what is the current approach to HT? Next. So in women in late menopause, the transition or early menopause, suppose the woman is in perimenopause. Like I said, it can be 1 to 2 years before the woman stops menstruating. She will require hormone replacement. I would say hormone therapy, because this woman is experiencing vasomotor symptoms. But this is the age where they can even be a freak pregnancy, freak ovulation can occur. So you can use a low dose oral contraceptive, cyclic combined regimens. But if the woman is scared of using progesterone because of the risk of breast cancer, the best thing is to use a combination of 17-beta estradiol with natural progesterone like micronized progesterone or dydrogesterone. And for vasomotor symptoms and mood disorders, the best is to use estrogen. And predominant mood disorder, if the woman is having, always take the help of a psychiatrist, because it may be a psychiatric problem rather than a menopausal problem. But if there is a predominant vasomotor symptoms, like I said, estrogen is the best drug to be used. No more than 2 to 3 years post final menstrual period. Like I said, this is a window of opportunity. You can give continuous combined regimen. Continuous estrogen progesterone therapy is given if there is a uterus intact. If it is not there, estrogen can be continued. Next. Now, surgical menopause, that is, if you are doing a hysterectomy along with bilateral oophorectomy, salpingo oophorectomy, then you have to give unopposed estrogen, and it can be started as early as possible. Start with a higher dosage, especially if the woman is in the 40s, because she is not still perimenopausal. So you have to match the estrogen which is being produced physiologically in her body. And then slowly, you can reduce the dosage and then bring it to a level where that is sufficient to prevent her menopausal symptoms. And transition phase, that is peri to menopause, a low estrogen oral contraceptive also can be used, which is very safe in these women. Next. Next. Now, what are the risks associated with HT? Because whenever we are counseling the woman, we have to talk to her about the symptoms. We also have to talk to her about the need for therapy. And the best therapy is hormone therapy. And what are the risks associated with the hormone therapy also should be explained to her in these days of medico-legal implications. Next. So osteoporosis, like I said before, osteoporosis, this is the best drug. Estrogen is very good. It decreases the incidence of hip fracture as well as the lumbar fracture. So the fracture of femur is much reduced, and lumbar fracture also is considerably reduced. But once you stop the therapy, the whole thing starts again. The risk increases. Now, coronary heart disease, like I said, within the window of opportunity, that is the first 10 years post-menopause. Like I said, menopause is a retrospective diagnosis. So you will have to know when she has reached a menopause. You can't be doing some hormone tests, though there are a number of hormones like FSH, AMH, and then the follicular count, antral follicle count, you can do it. But you can only predict that she may go in for menopause, but you can't be absolutely sure that she is in menopause in the perimenopausal period. So in this particular period, you can use estrogen. The coronary heart disease is definitely decreased because it increases the nitric oxide production and also decreases the visceral fat and also has a good effect on the lipid profile. But after 10 years, once the 10 years is passed, absolutely there is no use using this for a secondary prevention of coronary heart disease. That is what happened in WHI study. Now, whenever you are using estrogen progesterone, there can be breakthrough bleeding. And if there is a breakthrough bleeding, you can't ignore it. you will have to investigate the woman, because this is the age when there can be an endometrial cancer. So you'll have to thoroughly investigate her, and that also you will have to inform this woman, and there has to be an informed consent, and you will have to investigate her fully to rule out the endometrial or cervical or vaginal, whatever be the cancer. So you will have to ask her to come every 6 months routinely for a regular checkup, which may not be feasible for all women at every time. Next. Next slide. Next slide, please. Hello. Next slide.
Yeah.
Next slide. Next. Yeah. So, like I said, only if estrogen is used, the breast cancer does not increase. But if progesterone is used, yes, definitely it is increased. But progesterone, instead of the synthetic progesterones, if we use natural progesterones like micronized progesterone or dydrogesterone, the incidence is much, much less. But again, like I said, these women have to be called in regularly for a follow-up, and wherein you will palpate the breast. Clinical palpation is much better than a self-palpation. So you palpate the breast and you make sure that there is nothing wrong, because in these women who are on hormone therapy, if you can diagnose, if you are going to be following them up regularly, you diagnose the breast cancer very early, where the prognosis is going to be very, very good. And then, like I already mentioned about endometrial cancer, memory loss and dementia, I wouldn't talk much about it, because estrogen is in fact supposed to improve the memory. I don't think it has anything to do with the deposition of amyloid, which is the cause of Alzheimer's and dementia. So this is a little questionable risk associated with hormone therapy. Next. Next slide. Next slide, please. Yeah. Now, venous thromboembolism, definitely there is an increased risk of venous thromboembolism, especially in women who have had a history of deep vein thrombosis, or who are hypertensive, who have had a cardiovascular incidence already, or if they are very obese. In these women, it is better that we don't prescribe the hormone therapy and go for alternate therapies. Now, increased risk of urinary incontinence should not be seen with hormone therapy, because estrogen will increase the softening and then the plasticity of the vagina. And in fact, the local use of estrogen in vaginal creams, in fact, is supposed to improve the urinary incontinence, dyspareunia, and urge incontinence also. Next. So to conclude, it is always advisable to use hormone therapy, individualize it, use the appropriate hormone, use the appropriate route of hormone, and then you use it with the smallest dosage for the shortest period, and it has to be used only for treatment of symptoms and not for prevention of any disease. The risk to benefit ratio must be weighed before making a decision. Considering the risk associated with HT, we have to try out other safer alternative options. And I think, we have to go through this and look at alternative therapies which will have a risk benefit ratio, and which will also take care of all the symptoms of menopause, and which can be used for a longer period, unlike hormone therapy. Next. Thank you very much. Thank you. That concludes my talk. Now I hand over the mic to Dr. Maninder.
Ma'am, you can begin.
Yes. Hello, am I audible?
Yes, ma'am, you can begin.
Yeah, good afternoon, all my colleagues all over India. I think it's a great opportunity talking about menopausal problems because that is the way ahead for a healthy nation and a healthy woman also. So, orbit of menopause is increasing now, and as my previous speakers have highlighted, what was the evolution of the menopause and menopause hormone therapy. So, they have very clearly said perhaps the only constant in life is change. So the perhaps the time is has come for us again to revisit the menopause hormone therapy because where there are some situations where we cannot prescribe menopause hormone therapy, and we have seen that from the previous elixir of life to famine forever, it went completely out of picture, and adverse findings from these trials led many women to go for the alternative therapies to alleviate their menopausal symptoms. So we know that the use has decreased from 600 million human years of to 12 million current users only. But the women in menopause are much more than that. In India, only by 2030, 173 million. All over the world, 100, 1200 million women are there. And life expectancy is 46.2 years in India and 52 years all over the world. So that means there are unmet needs in these women who are suffering either silently or taking the therapies which are not effective. So we have to find the alternative therapies for them, especially for the quality of life issues. So which start earlier, even at the age of 40 years they start, and my previous speakers have very much highlighted those symptoms where quality of life issues are involved. That is the psychiatric problems, aches and joints, myalgia, fatigue, hot flushes, nighttime awakening, sleep disturbances, sexual problem, irritability, anxiety, low libido. Now, sleep quality, if some drug can alleviate, I think that is going to be a great help to these menopausal women because it's not only interferes with daily routine activities, but of course increases their chances of having metabolic syndrome and cardiac events also. So we have to help out these women. Current management, as my previous speakers have told, is hormone therapy or vaginal estrogens are pharmacological agents then for hot flushes or for osteoporosis. These are the conditions. So perhaps the time has come for us when we have to individualize the treatment because there may be women who, because of age, window of opportunity, DVT, cancer preference or personal preferences, or liver disorders or comorbidities cannot take menopause hormone therapy, but they do need the help. So there are the CAM or the classified complementary and alternative medicine, which was the National Center for Complementary and Alternative Medicine have put them into 5 category: mind and body intervention, biological like finger pressure, then phytohormones or various herbal therapies and homeopathy, and antidepressant, anticonvulsant, dehydroepiandrosterone, and exercise and all that. But today we'll be just in this session we'll be covering on the phytohormones or various herbal therapies which are available. All of us know by now that it is an hypoestrogenic state which is causing all these symptoms all over the body, central nervous system, breast, lungs, and I don't have to repeat them again because we have already highlighted the questions which are there, problems which are going to affect her quality of life. So estrogens basically are acting through receptors. So these are estrogen receptor alpha and beta. Now, alpha receptors are present in the uterus, ovaries, prostate, testes, breast, brain, hypothalamus, immune cells. And beta receptors, basically non-genital organs, GI tract, colon, bone marrow, vascular, lung, bladder, beta cells, and much of the brain also. Then they can either act through the nuclear receptors or they can act through the membrane receptors. Now, when they are acting through the membrane receptor, then the effect is very quick. But when they are acting through the nuclear receptor, the effect is slow to come. So, role of complementary therapies. Let's look into what the isoflavones, which have been used by millions of women all over the world, are they being effective or they are not being effective? Now, it has been found in the population-based studies that in the populations of Malaysia, China, Singapore, Japan, where more use of dietary isoflavones were there were less hot flushes. And phytoestrogens, they are acting through beta receptors, and they are from the plant sources only. But as compared to estradiol, their estrogenic potency is very less, maybe 0.2, 0.013, like that for the pumistrol, genistein, diazine, and all that. So mechanism of action of these phytoestrogenic is genomic. When they suppress beta, they are acting through beta receptors, so they suppress alpha, and breast stimulation is not there. So no increased risk of breast cancer is there. Non-genomic, they can reduce the vascular endothelial growth factor, they can reduce the tumor growth factor, they can increase the SHB and cause some cyclical changes, and they have been resulted in lower levels of cholesterol, blood sugar, and insulin also. So phytoestrogens are basically found in the food, and isoflavones, lignans, 3 groups are there which are found in soya products, red clover, unrefined grains, beans, and alfalfa or clover sprouts, or split beans or lentil. Now, basically, source of isoflavones is soya. Now, what does the studies say? When we have seen the smaller studies, they say there is a positive effect on vasomotor symptoms. But larger studies at SWAN and randomized controlled trials sponsored by NIH found no difference in isoflavones, or the placebo effect was not there. Same way, Cochrane summary, they said no evidence of these isoflavone or diet high in soya on the effect on hot flushes of dietary soya extract, red clover extract, or genistein did improve the hot flushes frequency, and equal reduced hot flush frequency. But 20 to 30% of the Caucasian women only, they have the enzymes or microflora to convert diazine to equal, and Asians they have in about 50 to 60% of the patient. So population. So that is why that cannot be effective there. And safety is of course there for the endometrium and vaginal cytology. So no conclusive evidence is there. Perhaps we have to do more studies. Same way that clover does not give us any conclusive studies, but in vaginal atrophy, they have been found useful in soya-rich diet, and 90 milligram of isoflavone are given equally as HRT and as compared to placebo. Heart, they have again found some studies where they have reduced lipids and improved flow mediated dilatation, and resting blood sugar is all association says this is very minimum effect. So despite NAMS also advises be cautious in advising in heart patients. Breast cancer, if used from the soya extracts or the soya diet from adolescent itself, then they can reduce the incidence of breast cancer, otherwise not. Black cohosh does not cause menopause, reduce the menopausal symptoms at all, and there is increased liver toxicity also with black cohosh. Same way, the studies have found that they are not effective in controlling the vasomotor symptoms. So bone loss, again, they are not effective. So what is the problem with the phytoestrogens which have been used for such a long time, that more trials are needed, trials are too small, there are confounding variables are there. Phytoestrogen may be implicated in diet in high in phytos, but they have low fats also. So bioavailability is individualized, because if you don't have the microflora converting them to active element, that cannot be effective. And few human trials are there on pharmaceutical products. So clinically not effective. There is DT56A that is some way effective on the nervous system and bone, and antagonistic effect on the estrogen receptor in the breast and uterus is there. So what are other complementary therapies like evening, primrose oil, Chinese herb, dong quai, ginseng, which are all the herbs, steeled, they don't have any effect at all. And steroid ganglion block can be tried for refractory cases, but still not very useful. Other complementary interventions include acupressure that can have some effect, homeopathy, osteopathy, hypnotherapy, nothing help at all. So the NIH concluded a survey that 36% of the Americans use some form of alternative medicine. So that means they do need that alternative therapy. So soya isoflavones have to be used throughout life to have some effect, and acupuncture can be used in rare cases, and cognitive behavioral therapy is effective when alleviating vasomotor survival, but that's not approachable by everybody. So what is new in the horizon? Let's look into it. So new on the horizon is ERR 731, which is an isolate from the roots of the repontic rhubarb, and it has two components, reponticin and desoxyreponticin. It has been used since 1950, registered in Germany in 1993 as phytomedicine. It is registered with the FDA as the food medicine, and with the our own Indian drug controller also. So this has been registered, this has been found to be acting through beta receptors and does not have any effect on the alpha receptor. So that means no endometrial hyperplasia is there, no breast cancer risk is there. Germany, it's available since 1993, South Africa since 2011, USA since 2009, and Canada since 2012. So now let's look into the clinical data. The clinical data, they have done the trials for 2 years. First, they had taken the randomized placebo-controlled blind trial. So they had given it for 4 weeks. They found the effective in all the menopausal related scale, quality of life issues. Then they placebo, for after 12 weeks, even the placebo participants, they were converted into active drug takers. 4 milligram was given daily, and then they also had a positive effect of all the MRSS scale parameters was there. So this study has been done for 2 years now, and for treatment of perimenopausal and menopausal symptoms, and only contraindications are pregnancy, suspected pregnancy, breastfeeding, or unexplained genital bleeding, or breast or uterine cases, which are active ones. So what is menopause rating scale? This is validated health-related quality of life scale, where psychological symptom, that is 4 symptoms, and all these symptoms are rated on 0 to 6 on self-assessment by the participant. Depression, irritable, anxious, exhausted. Somatovegetative symptoms, there is sweating, hot flushes, cardiac complaints, sleep disorder, or joint muscle complaints. And urogenital symptoms, 0 to 12 points again, 3 symptoms, sexual problem, urinary complaints, and vaginal dryness. So they are covering these 11 symptoms. So what was at the end of 2 years, no clinically relevant adverse effects were there, no adverse events were noted, and all the parameters, they had improved at the end of 2 years. This is how after 12 weeks, they are taking the placebo persons also into the active group, and they all responded. So same way they have done studies in the hot flushes, and the heart complaints, in the sleep disturbances, depressive mood, irritability, anxiety, physical and mental scores, sexual problems, urinary tract symptoms, vaginal distress, problems, joint and muscle complaints score on MRS. They all improved over the after 4 weeks, and within 12 weeks there was a statistical difference in the symptoms, and resulted even in menstruation and non-menstruating women, severity and frequency of hot flushes both decrease. So what is the safety and tolerability across 2 years of age is no significant changes observed across different parameters. Liver parameters they tested, hematology, coagulation, lipid, inflammatory parameters, male and female sex hormone binding globulin, body weight, vital parameters, blood pressure, pulse rate, vaginal smear. So there was no increased risk of cancer or pap smear. Our endometrial thickness was also not increased. Endometrial biopsies were also taken. So now we have proved that it's a safe, it's tolerable, because there have been no side effects except some cases of loose motion or diarrhea can be there. Otherwise, no side effects are not there. So first recommendation, now the patient comes to you, what you are going to do. That is what you have to do. So you have to assess that patient for her symptoms, and then see her risk factors. And if he is not risk of any other, though no comorbidity is there, So lifestyle modification has to be the first course for all the menopausal women. So dietary pattern, physical activity, exercise, stop tobacco, stop gutka, pan, alcohol, positive thinking, stress management, relaxation technique, and sleep hygiene. They should be advised to all the menopausal symptoms. And then you assess those patients for all these symptoms and put the patient on ERR 7314 milligram daily, and you assess her symptoms. If she is improving, you can give for a long, long period also, because so far, 2 years they have not shown. Even further studies are going. I think they will be that this is one way forward for all of us. So women with menopausal symptoms may choose, may not like to have the conventional HRT, or maybe because of some contraindication like liver disorder, DVT, or age. So clinicians should be aware of the range of options that are available with them to discuss with the patient what the advantages, disadvantages, specific risk factor, balanced evidence-based manner, and based on symptom severity, quality of life is the one thing. Thank you for all the references from International Menopause Society, Indian Menopause Society. Thank you very much for the kind hearing.
Thank you, Maninder ma'am. It was indeed a very informative session. So I think it's time to have a panel discussion, and also we will take some questions from our viewers who are connected live. So the first question to Dr. Basab Mukherjee. So the question is, how soon the physical, vasomotor, and psychological symptoms in that sequence appear in perimenopausal women, and which symptom precede the others?
So as we did mention in our discussion, that the physical, psychomotor, and what was the third one?
The psychological, physical, and vasomotor.
Vasomotor. So it varies. It is not always very clear cut, but generally we would say that vasomotor symptoms start early. They would start a few years, varying from 2 to 5 years before the actual age of menopause. But the other ones, psychosexual, vaginal atrophy, usually comes later. The other ones depends. So it always isn't very clear cut, the transition. A lot of women do not have one particular symptom around throughout her perimenopausal period. So it is not very predictive, but generally we know vasomotor comes in the earlier part of perimenopausal period. The atrophic changes take place a little later. And about the psychosexual, the sleep disturbances, the bone loss, the muscle loss, the anxiety that goes over time, but there's no clear-cut demarcation which one comes first and which one comes later. And some women may not have all of them.
Thank you, sir. So the next question I would request Dr. Balamba to answer. So we have two viewers, Dr. Vaishali from Bidar and Dr. Gayatri from Mysuru. So they have asked almost similar question on the premature ovarian failure. So in the premature ovarian failure, what is the dose of estrogen progesterone? Can OCP be used, and how long these young women suffering with POF should be treated?
In premature menopause, like I said, it is a hormone replacement therapy, because this woman is young and she has stopped menstruating because there is a deficiency of X in her ovaries. So in these women, we have to match the physiological dosage of estrogen and progesterone. So the best will be to start them on low dose OC pills, and this we continue till the age at menopause, that is around about 45 to 50 years. Then we change them over to the menopause therapy, hormone therapy, not the hormone replacement therapy. And along with this, you also have to take care of their vitamin D and calcium also, because there are other symptoms also which can be there along with premature ovarian failure, or now we call it ovarian deficiency, premature ovarian deficiency, or decreased ovarian reserve.
Thank you, ma'am. So the next question is for Dr. Maninder Ahuja. Dr. Bharti from Virudhunagar is asking, a patient treated with non-hormonal as well as Premarin for hot flashes after surgical menopause for dysfunctional uterine bleeding at 45 years. And patient was diagnosed and treated for triple negative carcinoma breast after 10 years and is still having hot flushes. Now, can they be treated with estrogen?
Yeah, estrogens. She has a hormonal dependent cancers. No, she had that triple negative cancers.
Triple
So
negative cancer.
yeah, so that it's better to give her a non-hormonal treatment, which is, I think they have tried even ERR 731 also. But if you want to give estrogens, even in the hormone triple negative patients, they can be given because they are not because of the hormonal positive effects. So if the lower doses you can give them, and especially if there are vaginal symptoms only, then you can give safely. Local vaginal creams can be given. And of course, I think you can combine with non-hormonal therapies also, because they also show some effect.
Thank you, ma'am. So the next question is for Dr. Basab Mukherjee from Kolkata only. Dr. Nandini from Kolkata is asking, what dose and type of estrogen do you use for hormone replacement therapy?
Yeah, I think we didn't discuss that. I think it was discussed mainly by Dr. Balamba, but we'll come to that. The usually dose conjugated equine estrogen is my first choice because it has been the most tested. So conjugated equine estrogen would be first, estrogen valerate would be second. But these are the two which we commonly use in our day-to-day practice. The dose would be the normal dosage. We don't start with the low dose usually. And as Dr. Balamba said very clearly, it's a hormone therapy now because you give it for a different purpose. The HRT terminology is gone except for the premature menopause cases. So, so the dose, so conjugated equine estrogen first choice, estrogen valerate second choice, low dose estrogen, low dose COCP, that's a separate discussion that would be in the perimenopausal period. That's third.
So Dr.
If
Basab,
the uterus is there,
yeah.
uterus is there, then we have to add the progesterones. And
Of
now
course,
we are
of
not
course,
using medroxyprogesterone acetate. We are using micronized progesterone or dydrogesterone, which is more metabolically friendly.
Absolutely. So if the uterus is, if she does not have a uterus, of course she has a uterus, there has to be a progesterone support. The progesterone support could be for LNG IUS or could be oral micronized progesterone, as Dr. Maninder has rightly put forward.
This woman underwent a hysterectomy for abnormal uterine bleeding. Why did they remove the ovaries?
I mean, that is not mentioned
What
here.
is her age? Age.
So age is mentioned as 45 years.
45 years
is
we
young.
cannot remove the ovaries.
Right.
We don't remove the ovaries.
I think
Yeah.
all the parents.
Right. So another question for Dr. Basab Mukherjee from Dr. Gayatri Radhakrishnan. She is from Mysuru. She is asking, can sarcopenia be arrested or reversed by intense exercise and high protein diet? I think it's
You should ask Maninder.
Women only. Yeah.
Okay, I'll refer it back to Dr. Maninder. I think she has the most
Yes.
experience among us.
Yes.
Menopausal symptoms. I'll reflect it back.
As I said, in all the patients coming at whatever age to you, you have to advise about calcium and vitamin D. If it's not, your requirements are not met in the diet itself. If they are not met, then you have to take. Then secondly, you have to adjust your diet also accordingly, because if you are losing your proteins and you are taking less of protein and your metabolism is also interfered with, then you have to take the proteins also. That is very important. And exercise, there is no substitute for exercise, I tell you. Even in as old as 100 years, they have done these exercises. And resistance and weight bearing, where you built up your muscles, is a must to be added into your routine exercise program of yoga or walking. And along with that, add a few weights to strengthen your back muscles, because that is where you are having to go to have your maximum fracture. Unnoticed will be there. And then you have to do strengthen your leg muscles, because hip fractures are there. And you have to do balancing exercises. That's how I always say dance, because that is the best balancing exercise. So please advise exercise.
But Dr. Maninder, she's asked you whether it's reversible or not. Can sarcopenia be, is it reversible with hormones? That's what the question was.
Hormones, not hormones. It's with the exercise. Hormones will be preventing the further loss.
Yes.
But they cannot reverse it back, neither BMD nor that. But the further loss has to be prevented, and that should be there because sarcopenia and osteoporosis both go hand in hand. So if you are having sarcopenia, you will have low bone mass density also. So please strengthen your muscles. To strengthen
And
your
most of the falls are because of sarcopenia rather than osteoporosis. Because of the fall, they have a fracture. So the sarcopenia also has to be addressed, and osteoporosis also will be addressed with exercise.
both separately.
Right. And the next question is from Ludhiana. Dr. Vaishali Grover has asked that please give us the dosage schedule of estrogen therapy in postmenopausal women.
Postmenopausal?
Postmenopausal women dosage schedule, it has to be individualized. It is now, can I answer?
Yeah, please, ma'am. Go ahead.
Yeah, please go ahead.
Yeah, now there is no fixed dose schedule for anybody. It's no more replacement. It is a therapy. So that means we have to individualize for all the patients, depending upon their risk factors and how they are presenting to us, which symptoms they are presenting and which risk factors are there. So depending on that, you individualize the hormone therapy for those patients. Now again, like we mentioned, if there is no uterus, then we have to give the estrogens only. But if the uterus is there, then we have to give the other hormones also. But if there are risk factors for osteoporosis, then we have to give a different type of hormone. If she is beyond the window of opportunity, might be we have to give the other drugs also. So that is why we have to individualize it depending upon the patient's need. So we cannot tell you give this doses.
Can I add also here? Yeah.
Yeah, please, ma'am. Go ahead.
Yeah, because see, the window of opportunity is the most important thing, because the Gayatri didn't mention the age of the patient. Post-menopause means, once the woman has reached menopause, which is a retrospective diagnosis, within the 10 years, we can put them on hormones. That is hormone therapy. It depends on what symptom she is presenting to us with. If it's a vasomotor symptom, yes, definitely estrogens have to be started. And if the uterus is there, then you have to add progesterone at least for 10 to 12 days, preferably micronized or dydrogesterone. If the uterus is not there, only estrogen can be given. Start with a higher dosage of estrogen, then bring it down, and slowly, once the symptoms disappear, maintain the dosage for some time, stop it and see. If the symptoms don't return, you can stop it. If they recur, you can restart. And of course, you add calcium and vitamin D, exercise, diet, everything. It is a holistic approach.
Thank you, ma'am. Next question is from Dr. Nilofar. She is asking, is ERR available in India? What is name? I think it is for me. Yes, it is available in India as the name of the brand is Estro Ease 4 milligram tablet. Another question is, how long ERR 731 should be given? Question from Dr. Sachendra Das from Guwahati to Dr. Maninder Ahuja.
Yeah, this is the beauty of this product, that this can be given for a long time, because it has been in use for the last 21 years, and so far no side effects have been reported with this drug, because it is being given as a food medicine. So as long as the patient can afford, wants it, has the symptom, she gets improved, she does the lifestyle modification, then she may not need it. But till the time she needs it, she can take it for a longer period also. And people have been given for a longer period.
And another question is, although doctor has forgotten to mention his or her name, the question is that what all investigations or the screening should be done before starting ERR 731?
Yeah, that is very important question, because it's not because of the ER 71. It is because of the holistic care of health of women, because that is the opportunity you are getting to diagnose that patient for various problems. So in all the patients coming to you midlife, you have to do the basic hemogram, CBC, height, weight, BMI, complete family and personal history of exercise, and family history of cancer or metabolic syndrome or diabetes. Then TSH we have to do, TVS we have to do, to find out if there is any already existing pathology, because our women don't come to us at all unless they are at the end stages only. And then if a pap smear, if had not been done, should be done. It's not related to ERR 71. It's related to the holistic care of health of women, for which we are all sitting here now.
Right. So another question is, can we use or start ERR 731 soon after surgical menopause?
See, we just don't have any window of opportunity for this. That is the beauty of it. So you can start anywhere, whenever you feel like trying, because it's not going to have overnight effect. After 4 weeks you'll have some effect, then after 12 weeks you'll have a statistical effect will be there. So you can start, and if the patient is having acute symptom, I suggest you can give even hormone therapy for a small time if she needs it along with it. Then you can taper it off later on.
Right. So another question is, ma'am, can we use the ERR 731 or Estois along with hormone replacement therapy?
I already said, yes, of course, we can give when hormone replacement therapy is really needed and required. We cannot omit that therapy.
Right. And Dr. Preeti Sharma from Jodhpur is asking, 52 years patient, menopause since 2 years, predominantly vasomotor symptoms and osteoarthritis as a comorbidity. So what would be the dose of estrogen if has to be used, and ERR 731?
Why should we use estrogens? She's having hot flushes? No.
Yes,
Osteoarthritis?
vasomotor symptom, yes, hot flashes are there, and comorbidity is the osteoarthritis.
I think for osteoarthritis, anyway, we don't have to give the hormone replacement therapy. But hot flushes, of course, we can start with the ERR 731 now because we have got it available. And if within 4 weeks she responds to them, then she does not need menopause hormone therapy, because we want to find the alternative to menopause hormone therapy wherever it is possible. But if she does not respond, because she is there with them anyway for the last 2 years, so we can take another 4 weeks with proper counseling. If she is not happy with it, then we can of course give her menopause hormone therapy.
I think one important point to take home is that hormone therapy works best for vasomotor symptoms. There's nothing better than hormone therapy, but we need to have a pre-hormone therapy. Some checks would be required. And also, as Dr. Marinder said, if the uterus is intact, you need to give progesterone protection, and you need to have regular follow-up. And it's a smallest dose in the shortest period that still holds. So you can start with 0.625 conjugated equine estrogen with a progesterone cover, give it for 3 months, 6 months, see her and re-evaluate her. The option of non-hormonal medicines is always there, but hormonal therapy is the most tested, is the most effective for vasomotor symptoms and many menopausal symptoms.
Yeah,
Another
course,
thing to add is, yeah,
but the patient
osteoarthritis is
priority
not part of menopausal symptom. Osteoarthritis is not part of menopausal symptom, that we all have to understand. No. It's an aging process. It's an aging process, not related to estrogens.
So the next question is that how should we manage osteoporosis, which is post-menopausal, by Dr. Shobha. She's from Kolhapur. And does ERR 731 also acts on this bone health part? So first question I think is from Dr. Basab Mukherjee, that how to manage the osteoporosis, which is post-menopausal. And the second question is from Dr. Manindra Ahuja. Has ERR 731 any role in bone health?
Yeah, I think we didn't discuss much about the management of osteoporosis. It was beyond the discussions which we had today. But again, as we said, Dr. Maninder has already elucidated that maintaining high physical activity is a very integral part of aging process. So as you have more physical activity, as you have more exercise and a diet control, lifestyle would be always the first level of treatment. Osteoporosis, if it has been diagnosed by a DEXA scan, by a BMD, depending on how much the T-score is, then depending whether you would like to give more than calciums, you would like to give something like alendronate or something more than that. That would depend upon the level of bone loss that she has. About giving a hormone therapy just for bone loss, that is something which we have stopped. We do not give a hormone therapy exclusively just for bone loss. If she has associated other symptoms of vasomotor symptoms, something else it may be considered. But the important thing is possibly also to get an orthopedic consult in the picture. If she has osteoporosis is severe, then you may need to give something like zoledronic acid, something IV, which is given once a year. So a lot of other things are options which would need to be considered besides the regular calcium and vitamin D. So calcium and vitamin D does not treat osteoporosis. It helps in maintaining some amount of bone mass, but it doesn't treat it. So calcium and vitamin D alone will not do. You need to give something more for bone development in a case of established osteoporosis. Yes,
Even a monoclonal antibody is available now. Olimab
Right.
is available for osteoporosis.
Yeah.
Can I add?
Yes.
Yeah, please go
Yeah.
ahead. Go ahead.
Yeah. See, osteoporosis is very, very important topic, and I feel that the gynecologist should be treating it. Now, the patient who is 52 years, if he is osteoporotic, so then we have to definitely find out if secondary factors are not there. If there are no, and she is just osteopenia, then she is in the window of opportunity where she can be given menopause hormone therapy so that she does not go into osteoporosis state. But if she is already osteoporotic, that means BMD is below minus 2.5D, then we have to do her fracture risk assessment. That is very important. So depending upon her fracture
That's
risk
good.
assessment, whether it is more than 20% for the major or more than 2% for the hip fracture risk is there, then she has to be put on the anti-resorptive treatment, which is the bisphosphonates are there. Second line of drugs and zentronate. Third line of drugs as calcitonin and parathyroid hormone is there. Then we have sclerostin antibodies inhibitors, and we have denosumab also. So there is a plethora of drugs available, but we have to assess that patient in what stage his risk factor for fracture are there. That is very, very important to assess her fracture risk assessment, because osteoporosis does not kill her. It is the fracture which kill a woman, and we have to do that again. Here the fracture prevention strategies should be told to the patient, which are at the household or outside, or the balance exercises. So it's a long topic. But if she is in the window of opportunity, we can give HRT. That is indicated for prevention of osteoporosis, but definite osteoporosis, no role of HRT is there.
Right.
And another question, I think ER71
ER71
has not been studies have not been validated for prevention of fracture or prevention of osteoporosis, so I cannot mention.
So, ma'am, last question is from Dr. Sushila from Vijayawada. The question is for Dr. Balamba. In your opinion and experience, which estrogen is better, natural or synthetic?
See, natural estrogen is Premarin is time-tested 1.625 milligrams we have been using, and it's available as 0.3 also. But now 17 beta estradiol is available to us as estradiol valerate. 2 milligrams and 1 milligram is also available, but it has more potency than Premarin, because Premarin is an estrone, whereas this is estradiol. So naturally estradiol has a better potency. So if the vasomotor symptoms are very severe, you give a drug which has more potency. But like I said, the time-tested one is Premarin, where you can use it. And again, depending on the presence or absence of uterus, you add progesterone also, preferably a natural progesterone, not a synthetic progesterone.
Right. So before we wrap up, I would like to ask the very last question from Dr. Maninder. Dr. Siddesh from Hyderabad has asked about the vaginal dryness. You have already explained that local estrogen can be used. He's asking that can ERR 731 also be having effect on vaginal dryness?
Yes, studies have shown that it has effect on vaginal dryness. It has effect on dyspareunia also. So it can be used. That is what the studies have shown. When we go for clinical trials, we are doing already started in India. So when we will be doing present clinical trials, because our phenotype of Indian women is different than the Western part where the studies have been done. So perhaps I think high time they are already starting with the clinical trials.
So thank you very much, ma'am. With this, I would like to show the gratitude from entire Lupin family and also from all of our viewers who are connected today for the very insightful sessions followed by the questions and answer. Thank you very much to the entire panel who took time out of their busy schedule. And I'm sure that in future also we will continue with these kind of educational activities to reach more and more budding as well as the experienced doctors to share experience. Thank you very much. And thanks to all the viewers also for joining us. Thank you. Bye.
Thank you, Dr. Basam and
Thank you.
Dr. Basam for wonderful presentations.
Thank
Basam, you
Thank
were-
you, Maninder. Nice meeting you all this way. Thank you.
Thank you, Vinay,
Thanks.
and thank you, Lupin, for bringing us together.
Thank you, sir.
Yeah.
Thank you, ma'am.